Here. Good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce the speaker, we'd like to give a brief overview of our free programs for those attending for the first time. So we'll go over who we are, what is our programs, and introduce our speaker, and then we have opportunity for Q&A. You can at any time click on the Q&A button and add a question. They will be answered verbally in the order that they were provided. So again, my name is John Furman. I manage the National EDS Awareness Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter Deanna was diagnosed with hypermobile EDS in 2008, the same year my wife Carol passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to give EDSers with independent local support groups and spread EDS awareness in their communities. We've been a sponsor for many conferences and EDS events. We've started or supported over 100 EDS support groups and given them free web pages to link to the directory and map. In 2019, we presented a program to help leaders organize and manage the support groups and Facebook. Andy Harvey was a guest speaker for that program that was web streamed, recorded, and posted on EDS, leadeds.com. We received feedback that conferences provide valuable information and social opportunities, but many cannot afford physically and financially to attend in person or even online now. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We have over 100 webinars that can be searched by presenter's name, topic, and location. Our healthcare providers educational program was introduced in 2017 and provides free continuing education credits for healthcare providers to renew their licenses. It is receiving an overwhelming response from the medical community worldwide. Since nurses spend more time with patients than doctors, we introduced the first online EDS nursing program in 2020. We have 3 of the 6 programs already on the site. Many of our speakers have contributed to this newly released book, Disjointed. We have a book review on our site. Please sign up for our EDS Awareness Monthly newsletter. We introduced this in May of this year, and we've been issuing newsletters monthly. So here are a few links to the resources I just discussed. The slides will be posted on the site. You're welcome to review these. So let's get started. Just a general disclaimer, the presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems, please call 911 or the emergency services in your location. Always consult your doctor before making any changes to your treatment. For those attending live, again, I mentioned we have opportunity for Q&A at the end of the presentation. So click on the Q&A button and put your question there. So we're very pleased this evening to once again have Dr. Pradeep Chopra come back and talk to us about understanding EDS and managing it. So Dr. Chopra is a pain management specialist. He's currently an assistant professor at Brown Medical School and works full-time as a pain medicine specialist. Dr. Chopra did his residency in anesthesia and critical care fellowship in pain medicine at Harvard Medical School. He has a special interest in chronic complex pain condition and associated coexisting conditions, including Ehlers-Danlos syndrome and complex regional pain syndrome. So Dr. Chopra has several publications to his credit and is on the editorial board for a journal on pain. He serves on the medical advisory board for several chronic pain conditions. National awards include Compassionate Care Award, Lifetime Achievement Award, and Humanitarian Award. So again, we're very pleased to have Dr. Chopra join us. This is probably the 5th webinar he's done with us over the years, and we're really excited having him back. So Dr. Chopra, you can now share your slides and start your presentation.
Thank you for joining. And John, I can't tell you how impressed I am with all your hard work that you do in setting up these webinars. It's just amazing. And I personally can tell you that it has helped me a lot in many things. And I usually refer my patients to your website. In any case, I'm going to talk about Ehlers-Danlos syndromes and all that comes with it. So it's not, so as a pain specialist, I have to sort of look at the person as a whole person. And that is quite a challenging process. So this is a rather long presentation, and so bear with me. Okay, now how do I change my slide? Oh, there you go. All right, so so as John said, I'm a pain medicine specialist with a special interest in complex pain conditions, EDS being one of them. Did my training at the Harvard Medical School. Now I am an assistant professor at Brown in Rhode Island, USA. And I'm on a bunch of organizations, nonprofit organizations. I have no financial disclosure. I don't make money, I don't gain money, I don't get any kickbacks, anything like that. So how do you change the slide on this thing? Oh, you click on it, okay. So this is the standard disclaimer. So this is not medical advice. This is just for general information. And please discuss with your physician your own particular treatment. There are 3 things to remember in Ehlers-Danlos EDS. One is the connective tissue is weak. Now, I really want to stress on this is because I don't want you to think that EDS is a disease. EDS is more like a form of the human body. There are tall people, short people, black people, white people, and human beings come in all sorts of shapes, sizes, colors, and they have their own medical conditions. For example, sickle cell anemia is more common in the blacks. So we treat the sickle cell anemia. And so that's the idea over here is that the difference between a patient with EDS and no EDS is that their connective tissue is softer. And that's all the differences. So my connective tissue is not soft, but I have my own set of problems. The second thing is that they have very poor joint position sense. I'll get into that a lot more. And they also have comorbid conditions like dysautonomia, mast cell, and all that. We'll go through each one of them. So give me 1 second. How do I? Oh, okay. So one of the things to understand about pain is that you've got to find out what's broken. There's no such thing as treating pain. It's treating the cause of the pain. So if there's a noise coming from your vehicle, you can put on headphones and crank up the music and you won't hear the noise, but that doesn't mean that you fix the problem. So this is the same thing. Consider pain as a noise, and there is something that's causing this noise, and we need to fix that. And I'll give you an example. If your shoulder hurts, it could be from a dislocated shoulder joint. It could be muscle spasms because the shoulder joint is dislocated, or it could be pressing on a nerve or blood vessels, or it could be all of these or some of these. And that's that's our job as physicians to figure out, okay, you've got a shoulder pain. I can't just simply say it's because of subluxation of your shoulder joint. I need to figure out what else is causing this pain. And obviously, the treatment would be to fix the problem that's causing this pain. Similarly, on the same principle, you have to use a mix of treatments. There's no one magic treatment. There's no one magic drug or therapy or something that'll fix pain. You've got to figure out what it is, and not all of them. I call it the rule of 10. So if you can get 10% from one condition, say, I don't know, take a medicine, take aspirin, and if the aspirin takes care of some of the 10% of the pain, putting on a brace takes care of 10% of the pain, putting some heat takes care of 10% of the pain. So if you have 10%, you actually have 50% relief. And that's the principle, is to use little bits of everything. Don't expect one drug or one therapy to take care of all the pain. So I'm going to start from the head, and then we'll work our way all the way down to the toes. Head pain. So head pain is really common in EDS, and I've put a very short list over here. This list is actually in reality much longer. The number one problem is migraines. Now, I don't know if migraines is common in EDS or whether it's generally common, but migraines are one of the problems. Chiari malformation is common in EDS. Cervicogenic headaches, that's pain from the muscles around the head and the neck. TMJ, temporomandibular joint dysfunction, that's the joint chewing muscles that you use. Those can, so the joint can get dislocated and cause pain, or you can be grinding. Vision, blurry vision adds to pain. POTS or dysautonomia, that can add to headaches. So in a POTS headache, is a classical headache, is when you stand, you get a little bit of a headache. It increases, and then when you lie down, it gets a little better, not a lot, but gets a little better. Tethered cord syndrome can cause headaches. Spontaneous CSF leak can cause headaches. Craniocervical instability, or idiopathic intracranial hypertension. And I'm going to go through all of them. So if your complaint is my whole head hurts and I see double, I can feel throbbing in my ears, and it increases when I laugh or cough. So your headache gets worse when you laugh or cough. That's very critical. Double vision may or may not be there, but mostly if your headache gets worse with laughing or coughing, that's a significant indicator of pressure, increased pressure inside the head. It's called idiopathic intracranial hypertension, and there are many reasons why someone can have it. It used to be known as pseudotumor cerebri, but it's not called that anymore because it was causing obviously it was causing a lot of confusion. So these people have, the pressure inside their head is increased. And double vision is not early on in the disease, it's later on. So don't wait for double vision to happen to decide, oh, I've got hypertension. Ringing in the ears, it usually is a throbbing ringing. It pulses with your pulse. It can be, in EDS, it can be because one of the veins is narrowed down or because of Chiari malformation. So what happens is, think of the head as a skull, as a closed box. Blood goes in, blood comes out. The same amount of blood that goes in, the same amount of blood has to come out. What if the same amount of blood isn't coming out? There's more blood going in, less blood coming out, or not as fast. Then you start to have an increased pressure inside the head. And then there's Chiari malformation that can also cause increased headaches. Diagnosis, I've mentioned a few over here, spinal tap. And the reason I've crossed it out is because that's a bad idea in EDS. You can end up with a post-dural puncture headache, pretty sure. Most centers, most advanced centers don't do spinal taps in patients with EDS. Eye exam, again, the eye exam, eye changes happen late in the condition, and you don't want to wait for that. You want to get to it earlier. MR venography, that means they shoot some dye into your veins and look at the blood flow inside the brain. Upright MRI of the neck for Chiari malformation. And the treatment, again, as I mentioned, will depend on what's causing the increased pressure. So if there's increased pressure, now, if you don't know, if they can't find a reason, but they know that there's an increased pressure, there are medicines that you can take that will decrease the fluid pressure inside the head. If that doesn't work, then they can put a shunt, which sort of drains out the fluid inside the head. And of course, if it's a narrowing of the vein, they put a stent in there. And if it's Chiari, then of course, they do a Chiari decompression. My headache gets worse when I stand, and it almost goes away when I lie down. So this is critical. That means it almost goes down. Almost disappears when you lie down. Usually for my patients, I'll ask them, like, do you get 50% relief when you lie down? And if the answer is yes, then the diagnosis is spontaneous CSF leak. So over here, what happens is that our brain and spinal cord is floating in a closed compartment of fluid, and that fluid is called CSF. And it's closed, it's not going anywhere, or there's nothing coming in, there's nothing going out. But what happens in EDS is that they sometimes develop a spontaneous leak. And when they develop a spontaneous leak, then the pressure inside the head actually drops. So now they have a low pressure headache, and that's called a CSF leak headache. It can also happen if you've had a spinal tap or if you had spine surgery. It can happen in those cases also, but it's common and it can also be spontaneously, no reason, and you can have a spontaneous CSF leak. So the treatment is in different steps. So first thing is to increase your oral fluids, and you hope that that leak will close by itself. Increase your caffeine. Now, increase your caffeine is not, I don't really recommend drinking a bucket full of coffee or tea or something, but you can get Excedrin migraine that has enough caffeine in it to knock this headache out. An abdominal binder, something that goes around your belly, like increases your belly pressure, which then increases the CSF pressure. In some of these cases, they can do an epidural blood patch, or they can put an epidural glue. It's like super glue. They just stick some super glue into the spine, and it closes the hole. And if it's happened after surgery, then they probably need to go back into the operating room to close up that hole if it doesn't close up by itself. So that's spontaneous. So this is, the headache gets worse when you stand, and it almost goes away when you lie down. This is, the headache gets worse when I cough, and I get this tingling in my hands and feet, and I have difficulty swallowing. So these are classical symptoms of Chiari malformation. Again, in Chiari malformation, I told you that the pressure inside the head goes up. So coughing, laughing will make the headache worse. They get tingling in their hands and feet, and the difficulty in swallowing may not be very obvious, but you'll notice that food gets, you choke on some foods, and that's called Chiari malformation. This is on the left. You can see that's the normal skull. Let me see if we can get a pen. All right, so on the left, this is the left. You can see this is the skull, and you can see there's a hole at the bottom of the skull through which the brain comes out and goes into the spinal cord, becomes a spinal cord. And at the bottom, this is the back of the head. And at the back of the head, you can see a cauliflower-like part of the brain that's called the cerebellum. Now, in Chiari malformation, for whatever reason, the brain gets pushed down into this hole. And so does a part of the cerebellum that gets pushed down. And then this is called the brainstem. The brainstem gets pushed down. And so everything gets like corks into the hole at the bottom of the skull. And so it causes pressure on the brainstem. It causes pressure on the cerebellum. Here's the thing. The cerebellum is responsible for coordination, for balance, and the brainstem helps in maintaining your blood pressure and symptoms of, so these patients also develop with symptoms, come up with symptoms of POTS at the same time. So what are the symptoms of So what are the symptoms of Chiari malformation? The most common symptoms are, like I said, your headache gets worse with coughing or straining, laughing. They have balance problems. They do have neck pain. It's the classical headache is at the back of the head. It's like a pressure head in the back of the head and goes into the neck. They can have difficulty swallowing. They definitely have poor hand coordination, they're pretty kludgy, and these are some of the symptoms of Chiari malformation. So as you can see, again, as I said initially when I started is, yes, your symptoms are a headache. It doesn't mean that I can give you a headache medicine and your headache will go away. Unless I don't fix the problem that's causing the headache, it's not going to get fixed. So the diagnosis of Chiari depends on a good history and physical examination. So the physician should be aware of Chiari malformation, should know what to ask, how to examine the patient. And in case of patients with EDS, we recommend an upright MRI of the neck. So what happens is that the skull, when people with EDS, when they are upright, the skull sort of settles down onto the neck and on the cervical spine, and they have what is called cranial settling. So the head sort of settles down on the neck and they develop symptoms of Chiari malformation. And that's why it's important to have an upright MRI. This is TMJ pain, that's the jaw pain. This is from the temporomandibular joint. This is the distribution of pain in TMJ. So you can see it's pretty broad. You can have jaw pain, you can have headaches, you can have head pain, neck pain, upper back pain. These patients generally clench their teeth or grind their teeth. It's common in EDS. Recurrent subluxing the TM joint again and again can cause this problem also. So it's very closely related to neck issues. Again, they have a clicking noise in their teeth. They do clench. Sometimes their jaw locks up, especially if they open their mouth too wide. So moving on to upper back pain. So upper back pain is this part above the shoulder and the upper back between the shoulder blades. These are some of the reasons why patients with EDS have upper back pain. So one is shoulder instability. So if the shoulder joint gets all its muscles from the upper back, that's called the rotator cuff group. And so if someone has not just a little bit of instability, but if they have a lot of instability, then those muscles tighten up. And the second reason is rib subluxation, and I'll get that into more details later on. And then in POTS, you can have neck pain and upper back pain, what is known as the coat hanger pain. So it's like in this shape, like a coat hanger. And in women, it can be because of the weight of the breast tissue. So breast tissue, kind of heavy breast tissue, can pull you forward, and then your ligaments in the back are not doing a good job of holding you back. So your muscles in the back have to work extra hard. And so heavy breast tissue can also cause this upper back pain. Actually, that upper back pain also happens in non-EDS patients with heavy breast tissue. So how do you treat it? Obviously, if it's because of POTS, you fix the POTS. For patients with generally with women with heavy breast tissue, they can wear a sports bra with a racer back. I mean, if you're a guy and if you want to wear a sports bra, sure, you're welcome. But it's mostly for women. They can wear a sports bra with a racer back. So what it does is it holds their back, supports them. Or you can wear a compressive vest to support the spine. And I'll go into more detail on the compressive vest later on, because that is important for other conditions also here. So this is an example of a compressive garment. These compressive garments, what they do is they hold you tightly, because all your bones, in people with patients with EDS, their bones are loose, their joints are loose, and so their proprioception is poor. They don't have great proprioception, and these are some of the compressive garments that I've seen that work well. This particular one over here is from a company called DM Orthotics. They really do an amazing job working on this. And you can go to their website and look at what the products that they have. They even custom design, custom size it. So these are the ones that you see on the right. These are also for shoulder subluxations. So depending on which side your shoulder is subluxing, you can get one of these, or you can get one of the other ones for upper back pain. So moving on to the neck. So we come down from the head to the neck. So in the neck, there are two things. There are bones and there are muscles. So on the left, you can see bones and joints. And on the right, you see muscles. And as you can see, there are a ton of muscles are in the neck. Now, so the head is so imagine this as your neck, and this is the head on top of the neck. What happens is that my head is right now held onto the neck by ligaments, and these ligaments are like ropes. In EDS, these ropes are actually bungee cords, so the head tends to tip over. To prevent it from tipping over and maintaining your head position, your muscles work harder. And because the muscles work harder, they get tired after some time. And you find yourself sitting like this with your chin resting in your palm of your hand. You're either sitting like this with your chin, or you're resting your head on the back of a couch. And that often happens because you're allowing the muscles to rest. So oftentimes in these cases, a supportive neck collar can help. And I'll show you some neck collars that can help. You don't have to wear it all the time. You can only wear it as needed. You know, you've got a lot of work to do, you've got a lot of homework to do, you can wear a supportive neck collar for that duration. And what it does, it takes the load of your head off your neck. So that was because of the muscles. Remember, I showed you that there are two parts to it. There are bones and joints, and then there are muscles. So we talked about the muscles. Then you have also instability from the joint itself, which is called cranio-cervical instability. This is a whole topic by itself, but I'm just going to briefly touch on it. So the head and neck are stabilized by ligaments. And the problem in EDS is that these ligaments are like elastic bands. And so the head tends to roll off. The ligaments that hold the spine together, all the pieces of the spine together are also lax. And so the vertebra that sit on top of each other also move out of place. So these little guys shift. The vertebra over here in this neck, they start to shift back and forth. And that's called craniocervical instability. The treatment for this is much more elaborate, and it's mostly surgical. But for the time being, you can also try strengthening the neck muscles. You can also start using a neck brace. But I wanted to show you an MRI of what a craniocervical instability looks like. Now, one of the reasons why I'm showing this MRI is that I want to show you the importance of taking the right pictures. So this MRI is of the same person. He or she has got her head and neck in the normal position. And then on the right, you can see that this person has extended her head backwards. And you can see how much the spine flexes backwards. And that's the reason, because most MRIs, you know, if you go to the hospital and you get an MRI for craniocervical instability, you're lying on that table as flat as it can be, and you get a picture, but you don't get a picture of whether the vertebrae are moving or not. But once you get flexion extension films, you can see how the vertebrae move. So that's important to get that, and I'll talk about it a little more. So what kind of imaging do you need in craniocervical instability? Static pictures are not helpful, obviously. If I take a picture of my wrist joint right now, it'll look fine. But if I have subluxation of my wrist joint and then I move it and I take a picture, obviously I'm going to see my bones shift. And that's the reason why it's important to have more of dynamic pictures rather than static pictures. And one of them is called a digital motion X-ray, also known as DMX. The other one they can do is a functional CT scan. So you get a picture with your head flexed, then you rotate it to the left 90 degrees, right 90 degrees. I forgot to put in this, there's also extension of the neck. So these are some of the pictures that can be done. You can do the same thing with an upright MRI also. How do you manage it? It's a little beyond the scope of this presentation, but for mild to moderate instability, you can start with strengthening the neck muscles, and you can start with a hard cervical collar and then if it's severe instability, you have to consider surgical fusion. Not the best choice, but unfortunately that is, because that is where the spinal cord is. Right here, this black line you see over here is the spinal cord, and that spinal cord can get crushed. So that's in severe instability, they consider surgical fusion. Let me show you a sample of some neck collars. So this is the Vista multi-post therapy collar. There's actually a little balloon in here, and there's a button here. You press it and it inflates the balloon according to the shape of your face. The purpose of wearing a collar like this is not to stop you from moving your head and neck. That's not the purpose. The purpose is that it takes the load off the head. So the head weighs about 11 pounds, which is the same as a bowling ball. And it takes the load of the head off the neck and puts it on your collarbone. That's the idea of using a collar. Hard cervical collars. This is one brand. This another brand is called the Miami J collar. And they both have their own advantages and disadvantages. But this is another one that you can try. These are the two popular brands that are used. So this is what I just explained, was that what the cervical collar really does is it takes the load off the head, off the neck, and it places the load or transfers the load onto your collarbone, and that's the idea of wearing a cervical collar. On the same tone, you can't, using a soft collar is no use, because those soft collars, they change shape or get deformed very quickly. Now, dental issues in EDS, there are a lot. And it's not that, you've got to understand that if your teeth are not in good shape, it kind of affects your nutrition, which then affects the rest of your body. Now, like everything else, the gums are made of connective tissue, the teeth are made of connective tissue, and a lot of people with EDS will have what I call as soft teeth. So their enamel is thin and it wears off very quickly, and they get a cavity. And when they get a cavity, their dentist tells them that you're not brushing your teeth well, so they brush even harder, which wears out even more enamel, and they get even more cavities. They are prone to having gum weakness, so the gum tissue wears on. Every time you take a toothbrush and you brush your teeth, the gum tissue gets worn out, and before it can recover, there's time to brush again. They have crowding of their teeth, there's tooth instability, and then it also results in inflammation of the gums called gingivitis, which then affects all the increases risk of diabetes and arthritis in these patients. So the problem here is, there are two problems. One is that the bristles on the toothbrush are hard. And then the toothpaste itself, the commonly available toothpaste, are abrasive. So you can, if you feel it in your fingers, you can feel it feels gritty and sandy. They use that to clean silverware. And what happens is, because of these two, the toothbrush and the toothpaste, your enamel and the gums wear out much faster. So I came across this dental gel called Live Fresh. You can get it anywhere online. I think Amazon also has it. This one is not abrasive. It's a thing called chelating agent. So it essentially wipes your teeth off. So it wipes stuff off your teeth, and it's not abrasive at all. And they also have it as gluten-free, sugar-free. They don't have any salicylates. So that's for people who are prone to MCAS. So this is one of the recommendations. So on this same tone, let's talk about numbing medicines. As you know, that a lot of patients with EDS the usual numbing medicine, which is lidocaine, is ineffective. And I don't know, for some reason, dentists don't understand that. What we found is that marcaine or carbocaine work well in EDS. So it would make sense to call your dentist or whoever you're going to for any numbing stuff, tell them to, can you please use marcaine rather than lidocaine? And so they make sure they have it in stock. So I don't know why I went to tethered cord syndrome, but let's talk about tethered cord syndrome. In this again on the left is the normal spine, and you can see the spinal cord ends at L1. L1 is pretty high up. So in women, it's about the level of where their bra strap would end. It's about approximately at that level, the spinal cord ends. And then after that, you just have a thread hanging down, what's called a phylum. It's just dangling over there. And so as you grow taller, as people with EDS grow taller, as they move around, the spinal cord moves along with them. It's not fixed. In tethered cord syndrome, what happens is the phylum is fixed to the bottom of the spine, and when it's fixed to the bottom of the spine, it kind of tugs on the spinal cord. So as you can see, this spinal cord has now descended from L1 down to L3. And so it tugs at the spinal cord, producing different kinds of symptoms and many, many different kinds of symptoms. And I'll talk about some of the more common symptoms. And these are back pain. Usually they have unexplained low back pain. There's nothing in their MRI or CAT scan that shows something really terrible that would explain the back pain. They have what's called a neurogenic bladder. They have weakness in their legs. Their legs get weaker as they walk. They may have sensory loss, but usually have diffuse pain in both legs. It may not be in both legs. It may be one leg or the other. It might be right leg today. It might be the left leg tomorrow. So they have low diffuse, just kind of low back pain, no reason, a neurogenic bladder, leg weakness. Leg weakness is when they walk, they notice that their legs are getting weaker, and they have diffuse pain in both legs. What's a neurogenic bladder? In these cases, patients have urinary hesitancy. That means they have difficulty starting, or they just hold it for a very long time. They often have increased frequency. They go often. The thing is that people with EDS and that have tethered cord don't know how often they're supposed to go to the bathroom to pee. So they assume that going 20 times a day is normal. Everybody does that. And so unless they're asked, we really need to find out how often are they going. In some cases, it might be decreased also. Just don't pee all day long. They have urgency, can't wait, got to go. This one, they have a sense of incomplete emptying of the bladder. So they've just peed, but it feels like they haven't done a good job. There's still some urine left. They're not sure if they've emptied their bladder. And so there's some sort of a hesitancy, like, should I get up or should I not get up? So that's, and I don't see incontinence often, but you can have incontinence. Now, this is not incontinence like, okay, you just sneezed or, just laughed out loudly and 2 drops came out. It's not that incontinence. We're talking about real incontinence. But the more common symptoms are in sense of incomplete emptying of the bladder, increased frequency, and urgency. These are the more common symptoms that at least I see. So here's the thing. I didn't put in a lot of data and figures and numbers, but it has been shown that people with EDS who have Chiari malformation are very likely to have tethered cord syndrome also at the same time. Actually, 66% of them are likely to have tethered cord. So if someone gets diagnosed with Chiari malformation, just sort of look for symptoms of tethered cord also. You may or may not have it, but it's very likely that both of them are present. How do you diagnose tethered cord? MRI is not a useful tool for diagnosing tethered cord. It may or may not show up. Mostly it doesn't show up. So most neuroradiologists who are experts at diagnosing or seeing EDS, are used to seeing EDS patients, will tell you that an MRI of the lower back is not useful. But the neurosurgeon do get an MRI of the lower back to see if there are any other issues there. The most important thing is for diagnosis is a good clinical history and examination. A urodynamic study, also known as UDS, a urodynamic study is also helpful in case of urinary symptoms or what's called neurogenic bladder. So oftentimes a urologist can do what's called a urodynamic study and can diagnose if the person has a neurogenic bladder. And then together with that and an MRI that doesn't show anything else, and a good clinical history and examination will all point towards whether a person with EDS has tethered cord syndrome or not. And of course, the treatment is surgical. The treatment is surgical. So let's talk about subluxations and dislocations. You know, in what I have seen in the last 20 years is that most people with EDS have subluxations. They don't have dislocations as much. They're mostly subluxations. And this is what is it, a subluxation. So if you look at the subluxation, the capsule around the joint is overstretched. It's not broken. In dislocation, it's torn off, it's broken. So a symptom of subluxation is that all of a sudden they feel something like something's not right. This joint doesn't, there's something that's, the joint is not in the right place, and they have increased pain. And then they do a little wiggle or jiggle, and then all of a sudden everything seems fine. The world is a beautiful place. The joint is back in place. The muscles have all calmed down. You know, a better term for a subluxation is a slippery joint. So the joint slips in and out all the time. And a dislocation is a different story. The joint comes out and then it stays out, and then you need all kinds of things to put it back in place. So when a joint subluxes or dislocates, the pain is usually from the muscle spasms around the joint, which is normal, because if your joint subluxes and the muscles around the joint, you know, they're like, oh no, you can't sublux. And so they go into a spasm. And the reason I put this slide in there is because you might go to somebody for treatment and they'll say, oh, you got muscle spasms here. Let me just fix the muscle spasms. What happens is if you relax those muscles, then you're likely to sublux and dislocate the joints even more. So the treatment in this case is to prevent the subluxation or the dislocation and not treat the muscle spasms. You know, somebody can go and treat them with muscle relaxants or whatever, deep tissue massage, which might break the muscle spasm, but that muscle spasm is actually protecting you. And so it increases the chances of subluxation. Let's talk about this. This is a terrible pain, a rib pain. Ribs hurt for two reasons. One, they may hurt because the rib is subluxing. So, and then the other reason is costochondritis, which means that the rib is inflamed. Let me talk about rib subluxations, because this has bothered me for a long, long time in finding a solution for it. And I think I may have found it. Anyway, so ribs, what they do is all ribs meet at the back of your thoracic spine. And what they do is when they meet there, they form a joint. And because these ribs move up and down, so there are literally three little joints where the rib meets the spine. And like any other joint, they sublux. Why would they sublux? They would sublux if your posture was like this on the right. I don't know if you can see my little laser pointer. John, can you see the laser pointer? Anyway.
Yes, we do see the laser.
Okay, all right.
Yes.
Okay, I just didn't want to be waving my finger around. So what happens is when you're in the normal position, aligned position, the ribs are not being stressed. But when people with EDS go into this slouched over position, then what happens is the rib basically pops out at the joint. So they have a slouch. So the problem is rib subluxation. To prevent that, or the cause of the rib subluxation, is a slouched over posture. Now, a slouched over posture is common in EDS because the ligaments that hold the spine are also elastic. So most people, they're not slouched because they're lazy. They're slouched because their ligaments are just not holding them up. And so they get into a slouched position. And if this is the thoracic spine and this is the rib meeting it, what happens is when the spine bends over, the rib pops out. Like I said, to treat pain, you've got to find the cause of the pain. So the treatment for rib pain over here would be to make sure that you don't slouch. And how do we do that? One, this is an acute rib subluxation. So they use this roller. You can buy it anywhere. I mean, literally anywhere you can buy this roller. And if you have an acute rib subluxation, and like I told you, it's a really painful condition. So rolling over like that, and then there are some really nice videos on YouTube that do demonstrate how to use this roller. That will put the rib back in place. But that's not the cure. The cure is that we need to prevent the rib from coming out. This is temporary fix. Another way to put the rib back in is to what is called a cat stretch. So you do this little funky thing where you stretch your back, and it's supposed to put the rib back in place. But I'm not sure if this is a very useful position, because that's the reason why your rib subluxes in the first place. But if the roller doesn't work, then try the cat stretch, and it might help out. This again, wearing a vest, a supportive vest, will make a difference. So these are tightly fitting supportive vests that sort of keep your spine, your thoracic spine, aligned. And when it keeps that aligned, then that prevents the rib from subluxing. Moving on to the shoulder. The shoulder joint in general is a very unstable joint. It's by nature, by evolution, it is a very unstable joint. It doesn't have too many muscles around it as compared to the hip joint. So any laxity of the shoulder is going to cause muscle spasms around the shoulder joint. The other reason why people have pain from their shoulder is called thoracic outlet syndrome. That's the pain distribution in thoracic outlet syndrome. It's classically pain on the upper back, upper shoulder back, and then it goes down the arm, and it usually goes into specific fingers. It could be either these three or these two, but it's a very specific distribution. It also goes down into the front of the chest, into the pec. So this is a pec muscle, and it goes into the pec muscles, and that's the distribution for thoracic outlet syndrome. This is an extremely common condition in EDS, by the way. I think almost 80% of my patients have thoracic outlet syndrome in one form or the other. What happens is in thoracic outlet syndrome is this is the first rib and this is the collarbone. And between the first rib and the collarbone, there's a gap. And in that gap are nerves that go down your arm. They go between the first rib and the collarbone, and then they go behind this muscle, which is called the pec muscle. They call it the pec minor. It goes behind the pec minor, and then it goes down your arm. Now, what happens is if your shoulder is subluxing, then the pec minor goes into a spasm, and when it goes into a spasm, it squeezes the nerve. And if the collarbone subluxes because the shoulder joint is subluxing, then it again pinches the nerve going down the arm. In most cases of thoracic, the reason I brought this up was because in thoracic outlet syndrome, most cases of thoracic outlet syndrome in EDS don't really need any major treatment. But I do tell them about it. I do look for it and talk about it is because I want to reassure them that this is not coming from your neck. Because if you see, it looks classically that someone has a neck problem or a disc herniation in their neck that's causing pain down their arm. So this is the reason why I bring it up. And I haven't seen too many serious or severe cases of thoracic outlet syndrome in EDS. Most of them are very benign. The treatment is to try kinesiotaping. This is what it looks like. How you kinesiotape the shoulder joint. There are thousands of videos online on YouTube that will show you how to tape your shoulder joint. Botox injections. So one technique that we try is to Botox this pec minor muscle and the scalene muscle. And so you Botox these muscles, they become a little weaker and stretched out, and that sort of helps release that pinch on the nerve. If all else fails, then they go in for surgical correction, and that's pretty severe. That includes shoulder stabilization or removing the first rib. Let's talk about joint position sense. This is the problem that makes people with EDS kludgy. They bump into doorways, they bump into furniture, they drop things all the time. That's not the problem. It also causes a lot of instability in different parts of their joints. And so it's really important to understand what joint position sense is. It's also known as proprioception. So essentially, there are sensors in our joints, tendons and ligaments, that keep sending messages to my brain to let them know exactly where my body part is. So for example, if I have an itch on my head, I bring my arm up and I scratch my head. My brain knows exactly where the itch is. It knows exactly where my hand is, and then it sort of zeroes in on that itch. It helps you walk. So as you walk, as you lift up your right leg, your brain knows exactly how far your right leg is. It sends a message to your left leg to balance you, and that's how you walk upstairs, downstairs. And you'll see people with poor joint position sense tend to trip a lot when they're walking upstairs. So that's what happens is they get this, so the brain constantly gets this information, and then it then sends out messages to the rest of the body to maintain itself, stop you from overextending your joints, and stops your muscles from overstretching. So this is just a graph I wanted to show you, a picture I wanted to show you. So, this is where the signal goes up into the spinal cord, into the brain, and then the brain then sends signals to the arms. It sends signals to the chest for breathing. It then sends signals to the legs. And that's how the body moves in such a fluid manner. This gentleman is Adam Patopian. He won the Nobel Prize this year in 2021 for discovering the receptor that is responsible for proprioception. So we should all be grateful to him for discovering these receptors that actually, these sensors that send back signals to our brain. So I was ecstatic when I heard this. Proprioception, loss of proprioception is not just an EDS thing. It happens in toddlers where it's underdeveloped, in the elderly because their joints are degenerated. So that's one of the reasons why elderly fall a lot. Athletes because of joint trauma, and people who have had joint surgeries also lose joint position sense of proprioception. Now, this was the discovery that Adam made was that these proprioceptors are also found in skin. And so if we use something that is sort of skin tight, then the brain uses that signal to figure out where your joints are. And this is, again, I'm back to DM Orthotics, and they have done an amazing job of working on precisely this problem. So they have all kinds, as you can see, they have all kinds of lower legs, upper body, everything. So it doesn't have to be this company, but any garment that is skin tight will send signals from the skin back, help your brain understand where the joints are. And so these provide far more stability. So this lower over here, the red torso, you can see this kind of a garment would help prevent rib subluxation, would prevent hips joint subluxation or subluxation, or SI joint subluxations. Hand and wrist pain is exactly the same reason. There are two problems that happen in hands and wrists. One is when they hold a pen, for example, they don't know exactly where their knuckles are. And so they tend to hold it really, really tight. And that makes these little muscles have to work hard. They also have very stretchy fingers, and I call them jello fingers. So they have lax fingers, which means that when you have to hold something, you have to stiffen your finger. So because their fingers are so bendy, their muscles, they have to use a lot of extra strength to hold something simple as a pen. So how do you avoid that again? Same thing. You can wear a fingerless compression glove. They're sold online on Amazon. You can buy them as arthritis gloves. And this would give their joints, so this contact of this fabric with the skin over the joints sends a signal back to their brain. Again, for the jello finger or the bendy finger, you can use ring splints, and these stabilize the joints and give your fingers a little bit of a stiffness. There's a company that I came across called OXO. I found their products in Target, and they make all their kitchen utensils with a thick handle, thick rubbery handle. And you can see, I mean, this little peeler has a handle that's double its size. And that is something that's very useful for people with hand or wrist pain in EDS. They need to use utensils or things like these, a spoon or a fork with a thick handle like this. For pens and pencils, there are many. This is one by a company called Abelware, ABEL Ware. You can get that online, or they can get other things that kind of make the pencil thicker and softer, so when they grip it, they're not hurting their joints. So there's a question that I always get is, I went to my physical therapist, or I went to my doctor, and he said, don't wear braces because they make your muscles weaker. So I wanted to find out if that was true. And it's not true. Braces do not make muscles weaker. It's a common misconception, because no brace is tight enough to stop your muscles from moving. They don't go around muscles, they go around joints. So they stabilize the joints. So when they stabilize the joint, you're more likely to use those muscles. So for example, if I have subluxation of my knee joint, I'll try not to use my knee joint, which means I won't use my muscles. But if I put a brace on my knee joint and stabilize it, then I'm more likely to walk and use my muscles. So it's actually the opposite. Braces actually make your muscles stronger and not weaker. I'm going to go straight to the lower half of the body. To go to the lower half of the body, we go to if your feet and ankles are not stable, then that makes your knees unstable. And most times these knees are unstable to start with, which makes your hips unstable, which then throws your pelvis and spine off. So this is a excuse me. All right, so we're here. If your ankles are not stable, then that makes your knees unstable, which makes your hip unstable, which makes your spine unstable. Simple Jenga tower over here. So what are the problems with the feet and ankles? There are usually two problems. They have unstable ankles, and they may have flat feet. What is an unstable ankle? Right here, you can see it when they walk, they roll their ankles. See this? That is a no-no. Can't do that. That causes a lot of problems. So oftentimes they roll their ankles, and when they roll their ankles, they pinch a nerve. Right where my pointer is, there's a nerve here, and that nerve gets pinched. And when that nerve gets pinched, they have pain in their legs, and they develop drop foot, and they tend to trip. So how do you prevent rolling of the ankles? High top shoes. Just one condition, these high top shoes must have laces on them, not a zipper. There are all kinds of high top shoes. This is just a random selection I put over there, but there are all kinds of high top shoes you can get, and they are the best for keeping your ankle nice and comfy and cozy and stable. Shoe inserts, there are all kinds of shoe inserts available for, this is mostly for people who have flat feet. And they have a deep heel cup to, sort of keep the heel in place, and then they have an arch, and it's made of a solid material. It has to be solid, not flexible material. A good company that I found is a German company called Pedag. It's again available online, and I've personally kind of tried it to test it and seen how they work. Moving on to the knees. So once we've stabilized the ankles and the feet, we now need to stabilize the knees. So what are the problems with the knees? There are two problems here again. So the kneecap slips around. It's a hypermobile kneecap, hypermobile patella. And then they have hyperextension of the knee joint. So over here, this picture shows you what a hypermobile kneecap looks like. What it does is it makes the it makes the knee much more unstable, and that it contributes to the instability of the knee. It also causes pain in the thigh, in the front of the thigh, and so it's important to stabilize the kneecap. This is a hyperextension of the knee joint, and so you can see it's bending backwards. So the normal knee is supposed to be like this, and in a hyperextended knee, it looks backwards, and that makes the knee unstable. So together with the hyperextended knee and a patella that is slipping around, it really makes the knee unstable. I came across an interesting term while I was researching this. They call them banana knees, because it apparently looks like a banana. So how do you fix an unstable knee? This is one of the braces that I actually like, is because one, it has, what it does is there's a little donut here, hole to keep the kneecap in place. It has a hinge on the side that prevents your knee from hyperextending. The reason I like this one is because it opens up. When you unzip it, it opens up, and you wrap it around your knee. So it kind of wraps around your knee instead of tugging it all the way from your feet up to your knee, because most people have laxity of their fingers. It's very difficult to pull up a knee brace. So they have this one it wraps around your knee, and then it kind of Velcro the whole thing in place. It's by a company called MedSpec, and the brand is called Gripper. Again, I think you can get it through your insurance in the US, or you can get it through, online on Amazon. This is a kind of a subject very close to my heart, EDS in children. One of the things I like about seeing children is because the damage has not been done. By the time by the time you get to your adulthood, you've already done things. People with EDS have already done things that have made them, have destroyed their joints because they were not diagnosed in time. But with children, I have that luxury of saying, hey, listen, you can't do bungee jumping, or you can't do certain activities that might make your joints loose and lax. And that's one of the reasons why I like to work on them earlier. The problem so everything that I've talked about also applies to children, but the risk in children here is that the biggest risk comes from ignorant hospitals and doctors. They see unexplained bruising, they see dislocating joints, they see chronic body weight pain, they see anxiety, and what happens is they call child protection services right away, because they're bozos who just don't know what EDS is or have bothered to even learn about it. And of course, you've all heard these, EDS does not hurt, EDS is very rare, so you can't have it. Apparently only aliens have it. EDS what? So they get diagnosed with conversion disorder, or sometimes worse, Munchausen by proxy. And these are made by physicians who have no training in psychiatry. They are psychiatrists who will make this diagnosis, have no training in pain conditions. So neither of these two have any idea of what EDS is, but they're very good at making a diagnosis of conversion disorder or Munchausen by proxy within 2 seconds. And this has led to a lot of issues and problems in families. So how do you fix this problem? It's a struggle. It's a really big struggle, but first thing is first, before you go to a doctor or a hospital, check with other patients and make sure that the hospital that you're going to is not known for that. Some children's hospitals employ this doctors. They're called I'm blanking out. Their job is to look for they just diagnose these people with Munchausen by proxy or by conversion disorder without knowing anything. They're usually pediatricians. So before you go to a hospital for this, check with other patients. Go online, go talk to other patients who have the same condition, and figure out like, hey, listen, I'm going to this hospital. Do you have any advice? And you'll get some feedback. If you are in the doctor's office and he's looking at you, he or she is looking at you skeptically and kind of not believing you, just quietly slither away. Just quietly say, nice knowing you, have a nice life, and get away. I don't recommend, if my child, I would not recommend going to an academic hospital with this condition, because the first 5 people you're going to see are going to be doctors who have literally just graduated yesterday. They are interns and residents who don't even know normal stuff, let alone know a complex medical condition. So I would avoid academic hospitals. Unless, of course, it's an emergency and you don't have a choice, then of course it's fine. But otherwise, try to avoid that. If you're able and if you can afford it, choose a concierge physician. In my area, I have a group of concierge physicians, and they do a remarkable job of treating, helping out patients with EDS. And it's just, the results are so much better. So again, I said, stay away from children's hospitals. They are notorious for diagnosing people for conversion disorder without knowing what this condition is. There are lawsuits that have been put against these people, these hospitals. So rather than get into this whole thing, just unless it's an emergency, go there, or try to even avoid that and go to some other place where they can be treated. The other thing is, keep your pediatrician on your side. Keep him or her updated on your child's health, because the first thing they're going to do is call the pediatrician. And if the pediatrician doesn't know, you don't want the pediatrician telling the hospital, oh, I haven't seen this child in 2 years, or I don't know what this whole business about EDS is. So keep them informed. Don't expect them to treat EDS because that's not their specialty, but at least keep them updated. All right, moving on to dysautonomia. I just chose POTS because it's easier to say POTS rather than dysautonomia. But it can be there. Dysautonomia is an umbrella condition, and under this umbrella condition, there can be many different types of conditions, and POTS is one of them. What are the symptoms of POTS? These patients are lightheaded. So when they move from a lying down position to a standing position, they get lightheaded. They have palpitations, their heart is racing. Lots of fatigue, lots of fatigue. They may get headaches, but these headaches are different from a CSF leak headache. So when they stand, they may get a headache, but when they lie down, it doesn't really go away. It just gets a little better. They have cold hands and feet. They often get diagnosed with Raynaud's, lots of brain fog, and they also have this constant feeling of anxiety. And these are some of the symptoms of POTS. How do you diagnose POTS? You can literally diagnose this at home. You measure blood pressure and heart rate after lying down for 5 minutes. Then you do that again after standing up within 30 seconds. You again check their blood pressure and heart rate. And then you stand for 10 minutes and you do the same thing again. And oftentimes, I'll show you the numbers, but oftentimes we call it the poor man's tilt table test. And most physicians who treat POTS don't really do a tilt table test. They do this test in their office. There's other tests. The fancier tests are called Q-sweat test and the tilt-table test. If you have POTS and you get through a tilt-table test, it's brutal. Anyway, so the diagnosis of POTS is that if you are moved from a lying down to a standing position, your heart rate increases by 30 beats per minute. That your heart rate increases by 30 beats per minute, but the blood pressure does not change a lot, changes only a little bit. Or your heart rate goes to straight to 120 beats per minute in the first 10 minutes of standing. You also get lightheaded. In children, the diagnosis is a little more strict. It should be 40 beats per minute. So if your heart rate goes, most often people with POTS that I see, their heartbeats are, their heart rate is just sitting in a chair is 120, 140 beats per minute. So it's pretty obvious they have POTS. One of the problems with POTS is that these patients get diagnosed with anxiety. Let me explain why people with EDS have POTS. There are several reasons, but one of the common reasons is that we normally, when we stand, we pull blood down our legs, and my nervous system kicks in and it pumps this blood back up to my brain right away. And so this process happens instantly. It also happens in people with EDS, with the difference that people with EDS actually pull more blood because their veins are more elastic. So they tend to pull more blood. So if you look at your feet, oftentimes when you're standing, they're dark and red. And that's one of the reasons they get misdiagnosed as Raynaud's phenomenon. But anyway, so they pull a lot of blood. And so their nervous system is working extremely hard to pump this blood back up to their brain so the brain can get its oxygen. Now, this is the same nervous system that controls flight or fight. It's the same sympathetic nervous system that controls anxiety. It's the same system that controls flight or fight. And so patients with POTS often will tell me that they're sitting around, really nothing's going on. They're watching a boring movie, and all of a sudden they get through this wave of anxiety that just passes through them, or it always feels like they're on the edge. And that's true, but this anxiety is not coming from their brain. This anxiety is coming from their body, it's coming from their POTS. So the treatment between the two is completely different. Anxiety from the brain is different than anxiety that's coming as a result of POTS. Obviously, in that case, you treat the POTS. But here's the problem. Oftentimes, as you know, that EDS is more common in women. And when they have POTS, they also have these symptoms of anxiety. So they're like, okay, you know, it's all your anxiety. It's really not a problem. You've just got anxiety. And so just, you know, here, take this pill for anxiety and everything will be fine. So how do you manage POTS? I've actually built it up into two parts. One is for just everyday treatment of POTS. And then I've gone into, later on when I talk about fatigue, I'm going to talk about some more advanced management of POTS. So obviously increase salt by mouth. So take a salty diet. And there are, I don't know if you ever go to this website called Dysautonomia International. They have some amazing stuff on their website, and you'll find recipes for a salty diet. If you can do that, then try salt pills. There's a company called Salt Stick Vitasium. It's a good brand because they have these capsules and they're easy to swallow. Swallowing a salt capsule, this pill is really hard. So it's very easy to swallow. The other addition is that they have potassium, which is very helpful in patients with EDS to help with their fatigue. Drink electrolyte fluids, at least 16 ounces per day. So 1 commuter cup of electrolyte fluids. The common brands are Liquid IV, Known, Banana Bag, Drip Drop. They're all pretty good. I have nothing. It's all on your taste, literally just on your taste. Increase your water intake. So you need about at least 2 liters of water per day. Just imagine in your mind that you are dehydrated. That's what would you do when you're dehydrated? You would increase your fluids. You would increase your electrolytes. Compression tights must come up to the thighs, all the way up to the thighs. In fact, if possible, even up to your pelvis, which something like a pantyhose, that would help. I'm sorry if there are any men on this with EDS, it still applies to you, but I really don't have much for anything different to offer. There is a newer drug, relatively new drug called ivermectin that's been released in the market. I think it's been over 2 years or 3 years now. If your insurance is good enough to give you that, it's worth a try. It does help a lot, but you have to. It's only approved for congestive heart failure, and so it's kind of hard to get that. But if your insurance is good enough to get it for you, then it's worth a try. Exercising in pots is really important. Now, when I say exercising, I don't mean you need to do you need to do all those pump iron and do all those things in a gym. It's simply moving your muscles, very gently moving your muscles, and all your exercises pots should be done flat or reclining. Do not push yourself. If you can do 5 leg lifts, that's more than sufficient. Don't push yourself. If it's a good day, stay at 5 leg lifts. If it's a bad day, maybe do 3 leg lifts. So, and exercise whatever you can, but as long as you're pumping muscles, you're fine. If you go on YouTube, there are some really great exercise videos with supine exercise videos that you can have a look at. You can use technology. So Amazon has this product called Echo. Everybody knows Alexa. You can set up Alexa in different rooms of the house. Should you feel lightheaded and you need to call for help, you can simply, call out Alexa, and Alexa will then dial out a number or call emergency services. The Apple Watch is an amazing device. After 4, so 4 and onwards, I think the latest one they're coming out with is 7. Any of these will do. They do 2 things, Apple Watch. One is they record your heart rate. Now, I like looking at the trend on their phone and see what are the times of day when their heart rate really goes up, or what are the time that tells me that that's the time when they're most potsy, which is usually when they wake up in the morning. And so I can adjust the medicine according to that. The other thing it has is it has a fall warning. So if you fall or you're falling, it'll detect that fall and it'll call for help. Let's talk about mast cell activation syndrome. By the way, these subjects are very well addressed on John Furman's website, on the EDS awareness website, by specialists in these conditions. I'm just touching on the more superficial parts of these conditions. Mast cell activation syndrome, very simply put, feels like you have flu. You feel tired, you feel fatigued, you feel cold, you feel sick, you have no appetite. It's just exactly how you feel. It's like having flu. It adds to the fatigue, it causes loss of appetite, and it's a diffuse body-wide pain. Everything hurts. You touch somebody here and it hurts. And if they have pain at some part of their body that was there before, like if I had pain in my left knee because it was subluxing all the time, that pain becomes even more, it becomes even worse. It also worsens symptoms of POTS. So what are mast cells? Mast cells normally are found everywhere in the body. They're part of the immune system, and their job is to just hang around. When the immune system triggers, when it detects danger, it triggers these mast cells, they get activated, and then they release a bunch of chemicals that destroy whatever it was causing the damage, if it was a virus or a bacteria or something. But in mast cell activation syndrome, what happens is these mast cells are misbehaving. And we don't know why they misbehave in EDS. These are the symptoms of mast cell activation syndrome. And you'll see that these match up with a lot of other things. For example, in the brain, they cause brain fog, headache, dizziness, confusion. So you see how they match up. We talked about headaches and dizziness earlier. And then it can cause blood pressure changes. It can cause a fast heart rate, dizziness, fainting. In the GI system, it causes abdominal bloating, cramping. In in the urinary system, it can cause urinary symptoms of urinary tract infection. So they might have burning when they pee, or they might have bladder pain. They do cause asthma and wheezing. They increase joint and muscle pain. They cause hives and itches and rashes. So the symptoms of mast cell activation syndrome are very, very diffuse. In my mind, the treatment of mast cell activation has three parts. The first part is to take antihistamines, and these antihistamines are famotidine is the only H2 blocker we have right now. You can take Benadryl is a wonderful H1 blocker, histamine blocker. The only problem is that it causes sedation. If you can tolerate it, that's a great choice. If not, then you can either take Zyrtec or Claritin or one of those. Any cold medicine will work. The second part of the treatment is to look for take mast cell stabilizers, and there are three of them. There is cromolyn, chirotefen, and quercetin. Quercetin is over the counter. I call it pineapple in a pill. It's made from pineapples. You can get quercetin over the counter. The dose is about 500 milligrams twice a day. The third part, which is actually the most difficult part, is to look for triggers. What are the triggers? It might be something that you're eating or something that you're breathing. And I'll talk a little bit more about that. The other thing I want to bring up now is, in fact, it was in the news today also, is to avoid foods or drugs that have a color dye, like red or blue dye. These are notorious for causing symptoms of mast cell, triggering migraines. In fact, it was in the news today that in the UK, they have banned sprinkles that are coming from the United States, especially the red color ones, because that red color is banned in UK and Europe. And yet we have red color everywhere. We have it in our medicines even. So it's not easy to find drugs that don't have a color on them, but if you can, then go for that. What could be the triggers? Look for air quality. Is there mold in the house? Is there some kind of a dust in the house? Avoid rapid changes in temperature. So, if you're outside in the heat, don't just quickly jump into an air-conditioned room. Let cool down a little bit outside in the shade and then come in. Same thing when you come out from a hot shower. So avoid rapid changes in temperature. Place a HEPA is, sorry about the spelling. Place a HEPA room air filter in the room. Let it filter out everything in that room. Foods, I just mentioned a few of these foods, but there are many, many foods. And one of the things I can tell you is that you'll know if you eat that particular food, you'll know that you just don't feel right. Your stomach feels bloated and you kind of feel like tired and blah. That's not the right food for you. There are many types of diets out there. There's a low FODMAP diet. There's a low histamine diet. I don't like limiting people to diets. I just tell them, look for the food that you can tolerate, because after all, eating good, tasty food is one of the joys of life. Fatigue and EDS. This is another subject that has been, besides rib subluxation, this is another subject that has bothered me for years and years. So there are a ton of reasons why people with EDS have fatigue. EDS itself can cause fatigue. The muscles get tired just holding you up. POTS can cause fatigue because there's not enough oxygen getting to your tissues. Mast cell activation syndrome can cause fatigue. It just causes histamine and cytokine release, and it also makes POTS worse. Medicines that you're taking for whatever reason can also make your fatigue worse. For example, if you're taking some painkiller, that might make you sleepy. Or even like you're taking antihistamines like Benadryl, that'll make you tired. Pain can make you have fatigue. Poor sleep, a lot of people with EDS have very poor sleep, what I call a sleep inversion. They stay awake all night and then sleep all day. And then the last one is secondary mitochondrial dysfunction. I'm not too sure about that, but I've talked to experts on this and they all kind of agree that that's possible. So let's talk about these. We talked about, so in terms of treating fatigue, obviously you have to treat cause of this. And one of the causes, you treat the POTS, you treat the mast cell activation syndrome, you look at the drugs and see if there are drugs that you can change. So these are some of the things you can do. One of the things that I like doing is home oxygen. That helps both fatigue and brain fog. So you can buy this little gizmo. It looks like an old-time stereo system. It costs approximately $200 in the United States. This is the one website that I found that has a reliable, when I say, you know, I put on a few products here. For example, this one, I bought it, tried it in my office to see if it really worked. And so I do have a few junk oxygen concentrators sitting around, but then this one really worked well. So home oxygen, 20 minutes twice a day at 2 liters per minute by nasal prongs. You can buy these nasal prongs on Amazon. Then what I like is this is called a sequential compression device. It's not sold under that name. It is sold as a massager. But for those of you who have been admitted to a hospital for a surgery or something may know this. They wrap this thing around your leg and it kind of squeezes blood upwards. And so it's called a sequential compression device. So what it does is it squeezes the lower part first, then it squeezes the middle part, then it squeezes the upper part. Again, you can actually buy this on Amazon. The brand that I tried was called FitKing, and they sell it as a FitKing massager. If you look it up, you'll find it. It has to go all the way up to your thighs. Make sure there's one product they have goes up to the knees only. So what I have done over here is I'm squeezing this blood back up to your brain, because one of the reasons people have fatigue is because there's not enough oxygen getting to the tissues. There's not enough oxygen getting to the brain. So what I'm doing is I'm squeezing this blood that was collecting in your legs back up to the heart, which then is pumping it to the rest of the body. And on the way, I'm using an oxygen concentrator to increase the oxygen levels. So this is one of the techniques that has worked well for my patients, at least. The only downside to this is that you're pretty much hooked up to your wall outlet. They both all work on electricity. But if your fatigue and brain fog is that bad, you're probably not that functional also. So this will get you to a functioning level. This is in addition to whatever I talked about treatment of POTS and mast cell activation syndrome. Now, mitochondrial dysfunction is mitochondria are like rechargeable batteries. These batteries get charged and then they get discharged. And one of the things is that when people develop mast cell activation syndrome or they have issues, these mitochondria are not working well enough. And the treatment is often to try what's called a mineral supplement for mitochondrial dysfunction, often also called mitochondrial cocktail. A lot of the compounding pharmacies make them. GI. So this, again, gastroparesis is very, very common. That's where you get the bloating after eating. It can happen from mast cell activation syndrome. It can happen from POTS. A good drug to try is Resolor. In Canada and Europe, it's sold as Resolor. In the US, it's called Motegrity. I usually recommend a half to a quarter tablet at night, and that works it works well. If you want, you can always increase it. But again, managing your mast cell is important, because in most cases of gastroparesis in EDS, it's because of mast cell activation syndrome. Another reason for having abdominal pain is called MALS, median arcuate ligament syndrome. This is a pretty severe pain condition. These patients have upper belly pain. It's on the upper part of their belly, they get pain. It happens almost immediately after eating food. They get tired after eating food, they get sleepy. Exercise makes this pain worse. The pain gets worse when they stand. It gets better when they're lying on their side. These are the classical symptoms of MALS. I just put in this diagram not to confuse you. This on the left is a normal picture. On the right is the mals, is a patient with mals. What happens is these red snake-like things that you see, these are arteries that supply blood to your intestine. And this arch is called the median arcuate ligament. So this artery sneaks out under this arch and supplies blood to the intestine. In males, what happens is that the arch kind of squeezes this artery and it stops blood flow to the intestine. And that's what causes these symptoms. The treatment for this is surgical decompression. Again, this is important. There are different types of surgeries that are done. Going to an experienced surgeon who's done this a lot is important. Different surgeons have different ways of doing it. So I would explore this well to find out if the surgeon does this well. One of the techniques some surgeons will do is they'll just loosen up the ligament. And some surgeons, what they do is they also remove the nerve that goes with this artery. And that's the one that works best. Removing the nerve and loosening of the ligament is what works best. For muscle pain, Epsom salt bath is amazing. 2 large cups of Epsom salt, that's magnesium, and a bathtub and soak yourself. If you don't have a bathtub, you can't do it. You can use topical magnesium that's available everywhere. If your fatigue on your muscle spasm is really terrible, then you can do IV magnesium. For muscle spasms, not muscle just pain or muscle spasms, I like this drug. It's called Cinemet. It's an old drug that was approved for treatment of Parkinson's and restless leg syndrome. Can be used for treatment of, I use it for treatment of muscle spasms and works well. Most of these muscle relaxers that you get, like baclofen and all, they don't really do a good job. Cinemet does a really nice job. Again, I just want to touch on this a little bit on menstrual periods. So essentially what happens during a menstrual period is that the body is preparing for a pregnancy. And so all the ligaments loosen up, the muscles loosen up, everything softens up as if to prepare for a pregnancy. Once the period starts and the pregnancy does not go forward, then what happens is these ligaments go back to tightening themselves up. But they don't do it fast enough. And by that time, it's time for the next period. So essentially, these ligaments never get a chance to get tightened up, and the muscles never get a chance to stiffen up. The other thing is that it also worsens mast cell activation syndrome in POTS. It causes body-wide pain. It causes pelvic pain. So talk to the OBGYN about stopping the menstrual periods, not just using it as a birth control pill, but completely stopping it so as to give your body a chance to recover. You know, this is a question that's come up very often, and I wanted to address it. Ketamine for EDS pain. There's not much value in it. It's good for neuropathic pain, and it doesn't really have a lot of advantage in. There are patients with EDS pain, EDS who have neuropathic pain. In those cases, it'll work. But it's good for patients for just pure neuropathic pain. So I can't recommend it for all EDS patients, but I can recommend it in patients with EDS who have neuropathic pain. It's best given as IV, but it can also be given as a nasal spray or under the tongue. Opioids, this is the strangest thing about, one of the strange things about EDS is that they don't respond well to opioids. And the other problem with opioids is that it can worsen mast cell, it can worsen brain fog, fatigue, it can worsen gastroparesis. But if it does work for you, then use it sparingly when you have a pain flare, for example. It's fine to use it at low doses for your chronic pain. And when you have a pain flare, you can use it to manage your pain better. But what works well in patients with EDS is cannabis. It works well, for some reason, it works really well in EDS. It does not affect mast cell. It does not affect the GI system. It actually helps with nausea and all that. The trick is to have equal amounts of CBD and THC. That's the trick. So make sure that they have almost, it doesn't have to be very precise, but almost equal amounts of CBD and THC. You may have a little more CBD and a little THC, that's fine. Hemp CBD is not all that great. There's a lot of controversy about it. I would avoid it. If you really just have to take CBD, go for the marijuana CBD. Low dose naltrexone. So this was a drug that I first researched back in 2000, and then in 2012 I published the first paper on this, where I used LDN for pain, and it literally took 10 years for it to get into the mainstream. So it's a long story, but it does help with pain and fatigue because it kind of increases the endorphin levels, and endorphins we know are the most powerful pain-killing agents. The normal dose is about 4.5 milligrams per day. You can either take it in the morning or you can take it at night. In some people, it makes them a little sleepy, so I tell them to take it in the morning and, sorry, at night. And those who, in some people, it doesn't cause any problems. They can take it in the morning. But it's important that you take it only once a day, not more than once a day. A lot of patients with EDS are very sensitive to drugs, and I always start them at a really tiny dose of like 0.5 milligrams, and then I slowly increase it. But you have to give it at least a 6-month trial. It takes a long time for it to start showing results. In some cases, you can see it within weeks, and in some cases, it takes months. The only side effects that we've seen are headaches. That happens very rarely. Colorful dreams, and sometimes it gives you insomnia, and sometimes it makes you sleepy. But they're all transient. They don't last. They go away after some time. So one of the things about exercising, oftentimes physicians or physical therapists will say, you've got to push yourself, and that is actually counterproductive in EDS. That whole concept of no pain, no gain is absolutely wrong. It should not be applied to EDS at all. The first thing is to control the pain a little better, control the POTS a little better, and then you have to exercise under your limits. So like I said, if you can do 5 leg lifts, then stick to 5 leg lifts. Don't go more, don't go less. So always start low, whether it's a medicine or an exercise, start extremely low, no harm done. And then you can go up slowly on that. So this I just explained to you. This is one of my favorite subjects, service dogs. I can't tell you how many, I've had a lot of my patients get service dogs. I've helped them get service dogs. These are amazing. These are not pet dogs. They're working dogs. And in EDS, they help with POTS. They can actually sense that their owner is about to have an episode of dizziness or lightheadedness or even a seizure. They know which limb to protect. They protect their limb from being injured or touched. Having a companion like this who's keeping an eye on you all the time, making sure you're safe, gives your confidence a boost that you can go out. So a lot of my kids, teenagers who've gone on to graduate through college, could not have done that without a service dog. They help with balance, so you can hold on to the handle on them. They can call for help. They can pull open a door open. They can switch on lights, pull wheelchairs. And they, of course, if you're having a pain flare, they help with the anxiety that comes with it. These are some of the organizations I could find, but there are a lot more organizations that are doing this, and it's worth looking at them. This, again, John had earlier mentioned this book called Disjointed. It's a very credible book. It's written by some experts, and it's worth reading it. Obviously, everything doesn't apply to everybody. So if you don't have Chiari malformation, you can skip that chapter. So again, we look for credible medical information, and I would suggest this book. One of the things that I want to talk to you about was lipedema in EDS. So this lipedema, you can call it fat, is a different kind of a fat. There's a condition that causes excessive fat accumulation in the lower part of the body. So between the buttocks, the belly, and the legs. They have loose connective tissue. And this loose connective tissue makes space for fat to accumulate in there. It involves the buttocks, thighs, and calves. Sometimes I've seen it in the upper arms, but not often. Oftentimes, this fat is painful. So if you put some pressure on it, there's very painful. This is what it looks, lipedema in general. And these are different stages, actually. This is stage 1, stage 2, and stage 3. You can see that. But you can see accumulation of lipid tissue in the legs. And then you can see it in the abdomen and in the buttocks. A lot of women with lipedema have been noted to have hypermobility or EDS. And this fat is painful. It can be painful, not always painful. It can be painful. It is often associated with joint pain and hypermobility because, as you can see, it increases the load on the lower half of the body. So it affects the knees. You can see, banana knees right here. And then, so it does affect the knees, the legs. And it is common not common, but it is seen in EDS. And obviously, these are all missed diagnoses because these, basically they're told you're fat. And that's not true because this is not fat. This is lipedema. And so usual therapies like diet or exercise or even weight loss surgery does not make a difference to this. It may or may not be associated with lymphedema. So where your lymph flow is blocked. It may or may not be. I can't go into the treatment of lipedema because that is really another whole subject. But I have put in 2 websites, really nice websites that actually talk about joint hypermobility, EDS, and lipedema. This is called Derkham's disease. I do see this in a fair number. I won't say it's common, but I do see it in a fair number of patients. This is, again, they have fat nodules. So they have these little fatty lipomas over here, and they're excruciating. And these are very, very painful, and it's called Derkham's disease. Oftentimes, they are also associated with joint hypermobility and EDS. Coming to the last topic is long COVID, because, from the data that we've gotten so far is about between 36 to 46% of the patients who survive COVID develop long COVID. Long COVID these are the symptoms of long COVID: breathlessness, palpitations, chest discomfort, fatigue, pain, brain fog. It looks exactly like dysautonomia. As a matter of fact, it is dysautonomia. They have paresthesias, pins and needles, they have abdominal discomfort, joint pain, skin rashes. So it's a mix between POTS or dysautonomia and mast cell activation syndrome. In the patients that I have seen, a lot of them have dysautonomia, not as much mast cell activation syndrome. The treatment in these cases has to be a little more aggressive. So in this case, I can't say, just wear compression garments and take oral salts. This is much more aggressive treatment. They need to get them on IV fluids. They get stimulants. They also, again, I suspect mitochondrial dysfunction, home oxygen, and so forth. Mast cell, like I said, is not in all of these patients, but some of them have it. And again, you've got to be very aggressive about it. It doesn't depend how severe your COVID was. I mean, not yours, but anybody who's had COVID, it doesn't depend on severe. It could be a mild attack of COVID, or it could be a really severe COVID. It doesn't matter. Long COVID can happen in either of these two. So I just wanted to bring this up because it mimics dysautonomia a lot. It's like dysautonomia on steroids. And so with this, I want to thank you all for staying on and listening to my presentation. Thank you to John, and thank you to setting up the EDS awareness for setting up this presentation.
Great, thank you, Dr. Chopra. A lot of new information that we haven't seen before, which is really fantastic. Well, as you look into it, you get more and more and more, don't you?
I know, these guys, I'm telling you, the thing with EDS is, once you think you know it, they've come up with something new.
Fantastic.
I still remember mast cell. It's about 10 years old. And 10 years ago, we didn't know what mast cell was. And all of a sudden now we have all these EDS patients with mast cell. So once you think you know everything about EDS, they come up with some other condition in it.
Yeah. I wonder if you'd take a few moments to look over some of the Q&A. There's a lot of questions there. I'm not quite sure we're going to be able to go through all of them, but can you click on the Q&A tab and scan those?
Give me 1 second. Oh, here it is. Okay.
Let's spend about 10 or 15 minutes on that, or whatever your energy level is tonight.
So there was one question that said that I mentioned misdiagnosis a bunch of times, and she wants to know, how do you find doctors who can best accurately diagnose EDS? That is a problem. Your best bet is to, again, go on. That's the advantage of social media. You can go on social media. You can go to an EDS support group, and I tell you, EDS support groups are some of the best support groups you'll ever find. And you'll see people who are seeing patients with EDS on a regular basis, working on them. The problem here is that, in my case, for example, I'll see patients with EDS, I'll diagnose them with POTS, I'll diagnose with mast cell, Chiari malformation, or something like that. But then after that, and I'll also start them on some basic treatment, but after that, if I need help, I have a hard time finding someone to pick up the treatments. So getting a diagnosis and getting a picture is not that hard, but finding the super specialists, as I call them, like specialists for mast cell or a specialist for dysautonomia, is extremely hard. You can go to their websites. I know the Dysautonomia International has a physician finder. You can go to some of these and look for them. I can't answer personal questions over here. I can only answer general questions. There are some people who have put up some personal questions. This is a good one. What do you recommend for diagnosis of MCAS? And when there are so few allergists who understand the different ways it presents. That is absolutely true. The question is, what do you recommend for diagnosis of MCAS? I didn't put it in there because I didn't want this presentation to go all night. But what happens in mast cell activation syndrome is it's extremely difficult to diagnose by lab. So a blood test or a urine test is next to impossible because you actually have to be in a flare when they draw the blood or when they collect the urine. So that means you stop all your medicines, you wait for a flare, and when you're at your worst, feeling like flu-like symptoms and you're feeling miserable, that's when you're supposed to go to the lab and have them draw blood. Even then, the blood has to be frozen right away. And it's very difficult. Bottom line, is very difficult. One of the easier techniques that I found is, one is to go through the questions. So for me, what I do is I have a set of 25 questions and I have the patients answer those 25 questions. And if they answer yes to most of them, then you're talking about mast cell. There are the other way is that if you've had a GI biopsy for any reason, they've gone in there and they've taken a biopsy sample, you can get that staining. You can ask them to stain it for mast cells. The stain for mast cells is called CD117. CD117, 170. Sorry, yes, 170. You ask the pathologist to stain the tissue sample with CD117 and let you know how many mast cells were seen per high power field. Now, we don't know there's a baseline number, but obviously if you see a whole boatload of them, then you know it's mast cell. As far as the tissue samples are concerned, I think they keep the tissue sample for a few years. They keep them in storage. So you can always go back and ask your gastroenterologist or your regular doctor. There was a question about, does LDN help with GI motility? Yes, it does. There's one question about steroid shots. I don't recommend steroid injections easily in patients with EDS. And I know that I do, my other life is to do injections, but I don't recommend them in EDS. One, because steroids can weaken tissue. It doesn't do as much in people who don't have EDS, but in people who have EDS, it can weaken the tissue. Now, it's not bad if you need it once in a while, but if you have to get a steroid injection on a very regular basis, or you're getting a lot of shots, then it can do a lot of harm to you. How do you test for mitochondrial issues? There's no real test. That's the problem. There's no test. There are some genetic tests, but they're not reliable. So we just base it on clinical symptoms. A lot of them are personal questions, so I don't know. Okay, yeah, I forgot to, this is a question on costochondritis, and I forgot to put in the treatment for that. So costochondritis is, what happens is that between the ribs, there are 3 layers of muscles, and these 3 layers of muscles become painful. And when they become painful, then the ribs become painful also. And that's the problem here. Now, it's not in any textbook, but the only theory after all these years that I could come up is why people with EDS develop costochondritis is because when you breathe, you expand all your ribs and then you let go. So all your ribs move up, and then when you breathe out, all your ribs go down. And they all have to do it together. And that's where the problem is, that some ribs, because of joint position sense, because of proprioception, the brain doesn't know which ribs are moving at which position. And so the muscles between the ribs go into a spasm. And obviously, if you're breathing 17 times a minute, over time, these muscles start to become painful. There are some treatments out there. One treatment I like is to lie on your back with your knees bent, with your hips bent. You put a book on your belly button and you breathe in and out, lifting the book up and down. And that helps. Singing in loud tones, so high tones and low tones, singing helps, or playing a wind instrument also helps. Patients who, what about patients who don't tolerate anything tight on their body? That is a real problem, actually. So what do you do in this case with compression garments? So the problem here is not the garment, or the problem is that the skin is skin sensitivity, and it could be that the skin becomes very sensitive because most likely because of mast cell activation syndrome. Mast cell activation syndrome can cause increased skin sensitivity, and I would pursue that first before trying a compression garment. Does prolotherapy stabilize joints in EDS? In prolotherapy, it may give you some benefit, a short-term benefit, but it's not going to give you any long-term benefit because so in prolotherapy, they inject a little bit of dextrose around the joint, and then that causes irritation and scar tissue. The problem is the scar tissue is your scar tissue, which is weak scar tissue to start with. And so it really doesn't stabilize the joints well. But if you can, I mean, for temporary relief, you can try some of the smaller joints of the hand. It can help. But it's not a permanent relief. It's more of a very temporary relief. I think, John, a lot of them are very personal questions, and I can't use this forum to answer personal questions. But I've tried answering. Give me 1 second. This is a question. This is a question about the relationship between mast cell activation syndrome and small fiber neuropathy. So small fiber neuropathy is something that can happen. One, it can happen because of age. Number two, it can happen in mast cell activation syndrome because, let me explain what small fiber neuropathy is. So imagine the nerves in your body are like the roots of a tree. So they are thickest in the middle, and then as they go out, they become thinner and thinner and thinner and thinner. So by the time they reach your toes or your fingertips, they become really, really thin and small. And if you have an immune dysfunction, if you have an immune problem, then your own antibodies attack your own body or your own tissue. And so they attack these little fibers at your toes at the tip of your toes and tip of your fingers. And that results in small fiber neuropathy. In some cases, it's not painful, and in some cases it can be painful. But the treatment over here is to treat. So the mast cell activation syndrome. So the question was, what's the relationship between mast cell activation syndrome and small fiber neuropathy? So mast cell activation syndrome can be an immune condition, autoimmune condition. And that autoimmune condition is triggering your mast cell, which is also triggering your small fiber neuropathy. I think we're Cinemet dosing schedule, do you start at and taper up? So Cinemet was a drug I had recommended for muscle spasms. You can use it for restless leg syndrome also. The dose is actually 25/100. That's the strength of the tablet. And you can start with half a tablet whenever you're having a compression, whenever you're having a problem. Yes, so my experience with Cinemet, this was years ago, I came across some literature where it was shown that dopamine in the brain, in patients with chronic pain, they have low dopamine levels in their brain. And the only drug that really does increase dopamine levels was Cinemet. So I tried it, and it was helping these patients with muscle spasms, and that's how I started using it. So I've had about at least a couple of decades of experience of using Cinemet for muscle spasms. I think, John, we can end over here. A lot of them are personal questions I can't take.
Okay, no, that's fantastic that we had a really good reception of people attending, and we're going to be posting this recording and also the slides out on our site. And I think people are going to have opportunity to replay it. I'll also send a notice out to the individuals who registered for the program. And it'll be on our site, it'll be on our YouTube site and our Vimeo site. So I think we're going to get a lot of feedback from this information, which is really fantastic. So thank you, Dr. Chopra. I really appreciate this is, I think, your fifth webinar for us, and
I know.
continue to hang in there. So wow, we really appreciate it. Thank you very much.
Thank you. Very welcome. I've tried to give you practical tips instead of just saying, oh, just wear compression garments. I've tried to give people very specific practical tips to try. And, this is not a complete, this is not complete in any way for the management of EDS and all its symptoms. But, on the EDS awareness website, you'll eventually see different specialists coming in, talking about mast cell, talking about dysautonomia or neurosurgical problems. And it's worth listening to all of those. And the best thing you can do for yourself is to educate yourself. Don't let people talk you into snake oil treatments. There are a lot of them out there. Just educate yourself, answer your question, answer the question, what's the problem here? What's broken over here that I need to fix? And then go for it. And then will this treatment fix the broken problem? If they will not fix the broken problem, then it's not for me.
Yes.
Yeah.
Yeah, fantastic. Well, as I mentioned earlier, we do have over 100 webinars on our site. You can go to the EDS awareness /webinars or chronic pain partner /webinars, and you can find these webinars based upon the presenter's name, the topic, and the location of the presenter. And I think that's a good way to get yourself educated, like Dr. Chopra was saying, and find out more and more about the condition that you're having. So with that said, we'll call it an evening. And any final words, Dr. Chopra?
Now everybody have I don't know if there are people from different parts of the world. So have a good day, good evening, wherever you are, and stay safe. Thank you.
Thank you. Good night.
Good night.